So the fundamental physiology of CAH is very easy to identify, but it's very important to know the nuances of each pathways because that determines the various manifestations that we have. And we'll discuss one by one in a reasonably succinct manner to cover the entirety of this whole pathway. So as discussed, when we talk about CAH, we know that the overall process is regulated via the hypothalamic corticotropin releasing factor or corticotropin releasing hormone, which regulates ACTH, which regulates adrenal production. Now, there are three specific adrenal hormones. Cortisol is produced by around 10 milligrams. We can say 6 to 8 milligram per meter square per day is the usual endogenous production rate of cortisol. DHEAS is the most abundant steroid. It's around 15 milligrams. And we have got aldosterone, which is 0.1 milligram. Now, which other steroid in the body, I'm not talking about adrenal, is produced in huge amounts, much higher than these as well? But it is produced only in some times, not always. So what I'm asking is that which gland is producing equivalent amount or if not more amount of steroids in the body as adrenals? And it may be not even a gland, a small part of that gland. Manoj? And that production is huge. So how much testis will produce testosterone? Testosterone is usually not. And that happens in one of the genders in specific times. So one of the most hyperactive steroid producing gland is actually corpus luteum. Corpus luteum produces huge amount of progesterone. So when it is producing progesterone, it is actually more than the adrenal production because progesterone levels go really high. So that is the exception, but otherwise the adrenals are the most important. Now, what we are seeing is that there is a discrepancy between the amount of cortisol which is produced compared to aldosterone which is produced. So cortisol is produced 1,000 times more. When you see these linear pathways, you will say, okay, everything is equal. This is producing cortisol, this is also producing androgen, this is also producing aldosterone. But remember that you have got 1,000 times greater production of glucocorticoid than mineralocorticoid. So which deficiency is more likely to manifest glucocorticoid or mineralocorticoid, Manoj? If you have a deficiency, and when we talk about deficiency, it's not absolute. It's a variable spectrum. So considering that cortisol production is much higher compared to aldosterone production, deficiency of which compartment is more likely to manifest? Is it aldosterone or is it cortisol? Cortisol will be more affected because there, even if you have some less production, you will know it. While for aldosterone, you only need 0.1 milligram. So that deficiency will not be manifested early. That is the fundamental basis of what we know as is simple virilizing form of CAH, in which you have cortisol deficiency, but you have reasonably enough amount of aldosterone production, which will take care of. So this relative production is also very important to understand. Now, in that perspective, when you have cortisol deficiency, your ACTH will go up, the adrenals will become big, and you will have other hormone effects which will happen. So congenital adrenal hyperplasia, if you remember the pathway, all you have to remember what is distal to that pathway, there will be deficiency of that, and what is proximal to that pathway, there will be excess of that. This is very, very simple in that perspective, and we can then decide what aldosterone and this thing happens. So now if we talk about the adrenal production, we all know that cortisol is a major hormone along with DHEAS, which is mainly produced during puberty. So before puberty, you do not have that much DHEAS, and aldosterone, of course, is important. There are different zones in the adrenal, glomerulosa, fasciculata, and reticularis, which have differential enzyme expression. Now, what decides whether one particular cell will produce aldosterone or cortisol or androgen as a final product?
It basically depends on electrons.
Yes.
Because certain enzyme activity requires.
So, which is the crucial enzyme which decides everything? So 17-hydroxylase lyase activity in a way is a main determinant. If you have got no 17-hydroxylase lyase, you will produce aldosterone. If you have got hydroxylation predominant with no lyase activity, you will produce cortisol. If you have both activity, you will produce DHEAS. So the main branching enzyme, which we'll discuss later on, is 17-hydroxylase. And now why does 17-hydroxylase behave in that manner? Is the electron availability. You need electron donors. So if you have too much electrons, you will complete the whole cycle and you will produce DHEAS. If you have less number, you will produce cortisol. If you have no number, you will produce aldosterone. And this brings us to a very interesting scenario. You always have ACTH in the body. Why is it that DHEA starts getting produced only during puberty? So you produce aldosterone, you produce cortisol. Why don't you produce DHEAs? For gonadotrophin and for all the other pathway, we know gonadotrophin is not there, so testosterone is not being produced. But here, why does adrenarche happen all of a sudden? So what is the trigger for adrenarche? So, but how does the bone age mediate adrenarche? How does the body realize that now we should push, or what change starts adrenarche? So these are all the signals. But then what is the switch? The switch basically is the electron donors. So when the electron donors go above a particular level, you will have increased DHEAs production. So all mechanism is there to produce DHEAs. It is not being produced because you don't have that much electron. So this is an important concept to remember. And of course, we discussed about progesterone, which is produced by huge amount via corpus luteum. Now, Vibha, out of these 4 steroids, catecholamine is of course not a steroid, it's an amine, cortisol, aldosterone, DHEAs, and progesterone. Which is the most important for sustenance of human life? Progesterone. Why?
Progesterone supposed to that is equal to the viability of the
So if there is no progesterone, your uterine contractility will keep on continuing and you will have abortion, which will happen. Implantation will be defective. That is why we talk about luteal phase defect, in which a lot of progesterone supplement is given. So for fetus to continue, you need progesterone. Otherwise, you may have 0 cortisol, you may have 0 aldosterone, and of course, DHEAS is of no consequence per se. You will still be having a normal baby. That is why somebody with CAH is absolutely normal. He has no production of cortisol, but still mother is taking care of glucose. He has no production of aldosterone. So maternal, all the hemodynamic instability, sodium, potassium is taken care by the placenta. So the most important is progesterone to ensure the survival. That is why if you have complete side chain cleavage defect, you will never have a viable fetus. And in fact, earlier books used to say that if you have side chain cleavage defect, it will never manifest postnatally. But now we know that milder defects in which some progesterone is produced can manifest. So this is of course a spectrum which can produce. So most important of course is progesterone. In the mitochondria, the first enzyme, the first rate limiting enzyme of steroidogenesis has now come into the picture, which is the side chain cleavage enzyme. So when you say side chain cleavage, it is very simple. It will cleave the side chain. So what it will do, it will cleave this chain and this side chain. So it's a side chain cleavage. And from here, you will have a production of the first compound, which is pregnenolone. When you say "on" at the end, what does it mean? It is which type of compound? Cortisone, hydrocortisone, or testosterone. What does it mean? "On" means what? It is? So this is ketone. That's why you have ONE. So all these things like testosterone and all those things are ketones basically. So this is the keto group which is formed for the first time. So pregnenolone is the first compound which is produced. It has got no biological relevance. It's just an intermediary compound produced by side chain cleavage, and this is coded by 11A1 in that regards. So our pathway has now progressed. Side chain cleavage and star, these are working together. So star is pushing there and side chain cleavage is causing this, and it is producing this. Now suppose you have a complete defect at this point. What will happen?
But then progesterone will be not viable.
Yes, if you have some production like star, the patient may survive. SCC mild form will survive, but you will have pan-adrenal cortical deficiency. No aldosterone, no cortisol, no androgens. All of this will be presented. And what will happen to the adrenals?
Because of the high ACTH, there will be the high.
What type of adrenal? There's a specific term which we use for adrenal phenotype. So it is huge, very, very large compared to CAH, and lot of cholesterol. So cholesterol is getting accumulated, but it is not being used. That is known as congenital lipoid adrenal hyperplasia. So XYDSD with salt wasting, large adrenals, huge adrenals, think of a lipoid adrenal hyperplasia in that perspective. Now we have talked about pregnenolone, which is being formed. It will now move forward to the second most important activity. I'm not talking about in terms of biological, but very important from a physiological perspective. And we discussed about that when we talked about the branch enzyme of steroidogenesis. This is a 17-hydroxylase. Now this is very, very interesting enzyme. In fact, people used to say there are two enzymes, 17-hydroxylase and 17-lyase. But now we know that these are just part of the same enzyme. The activity of the same enzyme may vary in different regions. Now, what the first part does is a hydroxylation. So pregnenolone, progesterone is converted into 17-hydroxypregnenolone. So hydroxy group is added. So ketone to hydroxy. And progesterone becomes 17-hydroxyprogesterone. So hydroxylation is happening here. Now, from there is also an internal lyase activity, which is also there, which converts it into DHEA and androstenedione. So this same enzyme, depending upon its activity, will decide the fate of cholesterol or the pregnenolone. The pregnenolone, which is coming out from the mitochondria, if it does not get 17-hydroxylase, becomes progesterone, becomes aldosterone. If it gets hydroxylase but no lyase, becomes 17-OHP and becomes cortisol. If it gets both, converts into DHEA and androgens are produced from that perspective. So this requires POR as a group. So that's why we talked about 17 aromatase and 21 which require POR or oxidoreductase in that perspective. So 17-hydroxylase is the branch point of steroidogenesis. Pregnenolone with only 3 beta, no 17, will produce progesterone, which will then go on to aldosterone in that perspective. 17-hydroxylase will produce 17-hydroxyprogesterone, with 21 will produce then cortisol. But if it also gets lyase, it will then produce DHEAS and will produce testosterone. So now if you talk simply, zona glomerulosa will have no 17-beta hydroxylase lyase activity. Zona fasciculata will have mainly hydroxylase, no lyase, while reticularis will have got both hydroxylase and lyase. That's why you will have one hand aldosterone, second cortisol, and third will be androgens which are produced from that. So this is what we said. Glomerulosa, nothing is there, you produce aldosterone. Fasciculata, you have got hydroxylase but no lyase, cortisol, and reticularis, you've got both, you produce DHEA. Now remember, just by having these enzymes does not ensure that you have a production of DHEA. What else do you need for DHEA production? We discussed this. You need electrons. You need electron donors. If you have everything there, but you don't have an electron donor, the second process will not happen. And that is triggered somewhere around adrenarche, and that is why DHEA started getting produced at that time. So now we have discussed about the 17. The next important enzyme is 3-beta HSD. Now this was hydroxylase. The earlier one was also hydroxylase. This is hydroxysteroid dehydrogenase. So when we say hydroxysteroid dehydrogenase, what will it do? What would dehydrogenase do typically, Naveen? So structurally, what will do? When you have dehydrogenase, it will convert which group type of compound to which type of compound? They will convert. What is delta? When you say delta 5, what do you mean by delta 5? The double bond is at carbon 5. And this is converted by 3-beta HSD to our 4th position. So this is just a switch which is happening. So this is a switch which converts delta 5 compounds into delta 4 compounds. Now the 3 major delta 5 compounds are pregnenolone to progesterone, which is converted, 17-hydroxypregnenolone to 17-hydroxyprogesterone, and finally DHEA to androstenedione. So now what you're thinking about this is pregnenolone is quite useless unless it is converted into progesterone. You will have no production of aldosterone there. You need 17 OHP for production of cortisol and androstenedione to produce testosterone. So 3-beta-HSD is very, very important from that perspective. So if you have no 3-beta-HSD, what will happen? So theoretically, will it be similar to star? Theoretically. If you have no 3-beta-HSD activity, will it behave like star?
No, sir.
Why?
Because star usually has a great precipitation.
No. Side chain cleavage. Will it behave like side chain cleavage?
Theoretically, it has to be, sir.
So actually, if you say if there is 0 3-beta-HSD, I'm not saying 3-beta-HSD2, which is an adrenal hormone, but if you have 0 3-beta-HSD, there will be some differences. You will have more DHEA, you will have more 17-hydroxypregnanolone, but clinically these are useless. They are not going to cause any problem because DHEA is not going to be converted into andro. It is not going to work. So theoretically, the side chain cleavage and 3-beta-HSD will be similar because no progesterone, no aldosterone, no cortisol, no androgens. But the but comes here is that is basically a P450 enzyme. This is a hydroxysteroidogenesis. So side chain cleavage does not have a isoform. No extra adrenal activity is there. But for 3-beta-HSD, you have got an extra adrenal activity in which organs? So you have got the activity which is there in placenta, breast, liver, all those things, and this will cause peripheral conversion. So peripherally, you will have androstenedione production. Peripherally, you have 17-OHP production. That is why in 3-beta-HSD, you may have mildly elevated 17-OHP, which can cause confusion with 21 in that perspective. So now our pathway has progressed. Two big enzymes have come into the picture. Pregnenolone, now with 17-hydroxylation becomes 17-hydroxypregnenolone. From lyase becomes DHEA, and then 3-beta plays its role converting delta 5 to delta 4. Pregnenolone to progesterone, 17-hydroxypregnenolone to 17-OHP, and DHEA to androstenedione. There is also a parallel process happening. So progesterone may also be converted to 17-OHP, but this conversion is very less. Similarly, 17-OHP may be converted to androstenedione, but this conversion is less. So which now, Vibha, is the major androgen produced by the adrenal? DHEA is the major adrenal one, but it may also get converted into 3-beta-HSD. But you cannot have a direct androstenedione production. So what I'm trying to say is that if you have any person who has got adrenal hyperandrogenism, your DHEAs has to be high. You cannot have a normal DHEAs and you have a high testo, because that cannot be explained. So even if andro is being formed, it is via DHEAs, not via this pathway. Because if you look at this, you will get confused. Okay, why can't 17-OHP be converted into androstenedione? So this is a very minor picture. This is not going to be very significant in postnatal period. In antenatal period, there is an escape phenomena, which I'll talk about a bit later in that regards. So now progesterone can also be converted, but mainly remember, andro is not being produced in a huge quantity directly from 17-OHP. It is indirectly through DHEA. Now we bring into the second enzyme, POR, which has an effect on 17-hydroxylase, lyase, and both activities. So if you have a POR defect, you will have features of 17-hydroxylase deficiency as well in that perspective. Now we need to also remember the role of adrenal over time. So the fetal adrenal basically has got a huge fetal zone, a lot of intermediate zone, and a very small definitive zone. So what does the fetal adrenal do? What is the main role of fetal adrenal, Dr. Manan?
Mainly to produce the androgen and to make virilization and produce the sex hormone, not produce cortisol or aldosterone.
So you say that adrenals cause virilization, not the testes.
Adrenal and testis.
Not the adrenal, testes basically. So if you suppose you have no adrenals, still you will have virilization. Na? So adrenal does not cause, it produces DHEAs. Why does it produce DHEAs? So adrenal's fetal zone of adrenal is maternal factory for DHEAs, which is a raw material for estriol production. Now this is important. We always say that fetus is a parasite. It is getting glucose from the mother, it is getting calcium from the mother, but here the mother is actually getting DHEAs from the fetus and using it to produce estriol, which is important for pregnancy. So this fetal zone produces a lot of DHEAs. Now, if you have to produce DHEAS and you remember that pathway, which enzyme should be more, which enzyme should be less?
17 hydroxylase would become more.
Which will be less?
The hydroxylase would be
Hydroxylase is required because it will convert 3-beta HSD you do not need. If you don't have 3-beta HSD, a lot of DHEA will be produced. So it is characterized, the fetal zone is characterized by low 3-beta HSD, high 17 hydroxylase, and we'll talk about one enzyme, sulfonyl transferase, which converts DHEA to DHEAS. These are high. So the major product of fetal zone is DHEA. Now, anything else in terms of time-specific expression? Do you think some other enzymes are also expressed in adrenal for some time?
after 12 weeks, there will be production of cortisol to us to inhibit this.
After 12 weeks or before 12 weeks? Especially 8 to 12 weeks. There is some cortisol production to inhibit the androgen production, because otherwise it will cause virilization in females. So that's a very temporary cortisol production. That cortisol is not important for fetal well-being. That cortisol is basically to prevent virilization of the female fetus in that regard, but otherwise it's just a factory to produce DHEAs. So suppose a fetus doesn't have adrenals, what will happen to the pregnancy?
Continuation of sustainable pregnancy because of the estrogen being one of the major hormones.
But they will not, they will be able to survive usually, but you may find these when you are doing a triple marker. In the triple marker in the mother will measure estriol, and estriol may be low. This may be a marker that the adrenals are not working. This may be a MPHD, this may be a steroidogenic defect. So whenever you have got some mother whose reports show low estriol, think, I'm not saying this is the only reason, there are so many other reasons which can be there, but this may be because of a defective DHEAS production by the fetus, whether it is CAH, whether this is multiple pituitary hormone deficiency. It is known, reports have come which show that low estradiol, ultimately it was found that there is a MPHD in the baby in that regards, normally born, but then you have MPHD. So you produce DHEAS. Then as the child grows up, you have got more requirement of aldosterone and cortisol. So your activity of 3-beta HSD will go up. 17 lyase activity will come down. You will produce cortisol and aldosterone. Aldosterone anyways 1000 times less produced. So that is not that significant. Now, once you enter puberty, there is a bigger increase in zona fasciculata. And in that scenario, you will also have reticularis which will come in, and you will have more electron donors. So you will have hydroxylase and lyase activity both. You will have a production of DHEAS. So the age-specific expression, fetal adrenal predominantly producing DHEAS, the childhood adrenal mainly producing cortisol, and adult adrenal producing both cortisol and DHEAS with a minor production of aldosterone, depends upon the relative sizes of the different zones. Now, are the cells in different zones different? So what I'm asking is, do cells of zona glomerulosa come from different stem cells, fasciculata from different stem cells, and reticularis from a different stem cell? Naveen? So it is the environmental process. People have shown that these same cells keep on moving within the adrenal, and depending upon the environment, their nature changes. So it's the same. So you can produce all three from the same adrenal stem cells. This is important. So now coming to the most important enzyme from a biological perspective, the 21-hydroxylase. So our pathway has already produced progesterone, which needs to be converted into DOC, a very, very important compound for mineralocorticoid production, and 17-hydroxyprogesterone, which is converted into 11-DOC, which is essential for the production of cortisol. So this is a very, very important one. 90 to 95% of all congenital adrenal hyperplasia are because of 21-hydroxylase deficiency. Now, this also requires POR. So when we say POR, remember three things: aromatase, 17, and 21. So you have a mixture of all these three, which happens with POR defects. So now the pathway we already found here, progesterone and 17-hydroxyprogesterone. You have 21-hydroxylase, which produces DOC here, and 11-DOC here. So now, Dr. Manoj, if you have a 21-hydroxylase deficiency, quickly what will happen?
There will be no production from the cells to cortisol. There will be the pathway shift toward the Aldosterone and
So you will have deficiency of cortisol as well as mineralocorticoid and shift towards the androgen production. So you will have a XDSD or a XY with precocious puberty presenting with a salt wasting crisis. That is the typical one, which is the most common one. We all are aware about that in that regard. So now we are very close to the functional hormones. Remember, progesterone is formed very quickly. Now, why is it formed quickly? Any guesses, Naveen? It's so up in this in that.
definitely that is the responsible.
So evolution has made that producing progesterone doesn't require too many things. You just make it initially. But when you come to more sophisticated products, you need more enzymes. So now, till now, after progesterone, not a single functional product has been produced. But now comes the important enzyme 11B1, which basically converts DOC into corticosterone and 11-DOC to cortisol, which is our second most important product as far as the adrenal steroidogenesis is concerned. So if you look now, we have got 11B1, which converts DOC to corticosterone and 11-DOC to cortisol. So now if you have a deficiency of 11B1, shouldn't it behave just like 21-hydroxylase? Because you have no, it will also block aldosterone production.
No, sir. This is because DOC has a big mineral activity, which is producing high hormones. So in this case, all wasting will not be there.
So just as we said that theoretically 3-beta HSD and side chain cleavage will look similar, but because of peripheral conversion, 3-beta HSD will cause some virilization. Here also, if you talk about pure strict sense, aldo is also low, cortisol is also low, and you have androgen excess. So it should behave like 21-hydroxylase. But DOC is at a huge amount will work on the mineralocorticoid receptor. Remember, when we talk about increased aldosterone effect, we say aldosterone is high or not. If aldosterone is high or not, DOC is high or not. So DOC excess states will also cause DOC producing tumor, 17-hydroxylase deficiency, 11-hydroxylase deficiency will also cause hypertension and hypokalemic alkalosis. So this DOC excess will basically cause hypertension and hypokalemic alkalosis. Now, why is, so when will this hypertension manifest, Dr. Vibha? At what age? Right at birth? Then? Why?
Doesn't prevent it.
Manoj?
Don't present that in human beings, do not present with the high requirement of the aldosterone that time.
So what you need to understand is that if you talk about aldosterone, your levels are here, very high. DOC is somewhere in between. So in the newborn period, the requirements are very high. When we talk about 21-hydroxylase, we know that they may require 3 tablets, 4 tablets of fludrocortisone. So that's why at that time you do not have hypertension and hypokalemia. You will present mainly with salt wasting, mild salt wasting. And then they will switch to hypertensive form 2 months, 3 months, 4 months later when the tubules mature. So interesting phenomena is that if you have 11B1 defect, they will present with mild salt wasting, mildly elevated 17-OHP, but this will switch towards a feature of excess at around 3 to 6 months. So this is sometimes confused as 21-hydroxylase. So you have XX-DSD with mild salt wasting, slightly elevated 17-OHP differentials, XX-DSD, salt wasting, and high 17-OHP. 3 differentials, 4 differentials. So 21-hydroxylase obviously very high 17-OHP. Second we discussed 11-hydroxylase third, POR and 3-beta HSD. So basically, if you have XX-DSD with salt wasting, CAH 99% will be 21-hydroxylase deficiency, 17-OHP will be very high. But if 17-OHP is 10 to 30, start thinking of POR 11 or rarely a possibility of 3-beta HSD as well in that scenario. So now we come to the next aspect, which is the aldosterone group. So now this is the aldosterone synthase, which is there. So this converts DOC to aldosterone. Here, this is not a CAH. So if you have a defect of this enzyme, adrenals will not become big because ACTH will not get produced to a greater extent. So now this is producing aldosterone. This defect will cause isolated salt wasting, hyponatremia, hyperkalemia, failure to thrive. Will they have pigmentation? No pigmentation, because ACTH will be normal in that scenario. Now we have talked about production of three major group of active hormones: progesterone, cortisol, and aldosterone. The next one is now coming towards testosterone. So we are mainly talking about 5: testo and estrogen. These are the 5 major groups. So 17-beta-HSD is again a hydroxysteroidehydrogenase. If you have hydroxysteroidehydrogenase, it will have isoforms. As simple as that. They will have 5 isoforms. So what is the major role of 17-beta-HSD? Or roles? Roles in different organs.
Basically, convert endosterone to the testis.
So it produces testosterone in the testis, number 1. It produces what in the ovaries? Okay. What else? What else does it do? So in ovaries and testis, it is producing. It's a positive one. Where it is a protective one? Naveen? Most important. Placenta. So if you have placental 17-beta-HSD, it will save the fetus from the effect of testosterone and for the effect of estrogen. So if mother has high testosterone, it will get inactivated there. If mother has, otherwise male will always. So this is an important question to remember. Why do males not get feminized when they are exposed to such a high level of estradiol in the mother? Because of this placental 17-beta-HSD. Otherwise, there will be no male. They will all. So when you talk about diethylstilbestrol, what does diethylstilbestrol cause? When is it? When was it used? For what reason? So this was basically used in terms of a abortifacient and anti-abortion drug sort of a thing, and it caused male DSD. So it was like under-virilization. Now the reason is that DEF can cross the placenta, 17-beta-HSD cannot inactivate. So imagine mother's estrogen is hundreds, and if it crosses, every male will be feminized. So that's why you've got the 17-beta-HSD in the placenta. So this is there in the ovary, which produces estriol in that process. In the placenta, it has got type 2 and type 3, which acts on the testo and estrogen. So it protects both female and male fetuses from excess amount of levels in the mother, which are there. So this becomes important from that perspective. And then in testis, of course, you have got the 3-beta-HSD, which is there, and adrenal also, which is there. So do you think this adrenal production is significant, Manoj? No. How much testosterone is produced directly by the adrenals? So we have discussed the primary one which is being produced by the adrenal is DHEAS. So this 17-beta-HSD is there, but this will be less than 1%. So adrenals do not produce testosterone. They can produce testosterone, but they do not routinely produce testosterone in that perspective. So now we've got our pathway working subsequently. 17-beta-HSD will produce testosterone. And now we've got 4 hormones which are there, which are basically progesterone, cortisol. You have got production of testosterone and aldosterone. So the final one is estrogen, the production of which requires an enzyme known as aromatase, which converts androstenedione to estriol and testosterone to estradiol. Now, which one is a better substrate for aromatase? Androstenedione or testosterone, Naveen? So which one will produce more estrogenic compound? Testosterone will produce more. So if you have a testicular source of testosterone, you will have more gynecomastia than an adrenal source of androgens. Which one causes more gynecomastia? Adrenal androgen excess or testicular androgen excess? This we discuss. When you have adrenarchy earlier than gonadarchy, you have gynecomastia. So it is the adrenal products, which includes androstenedione also to a great extent, because testis produces testosterone at all. So that androstenedione is more likely to get converted into estrogenic compound as compared to testosterone. So this is important to remember, that these will have a better affinity and will produce more estriol. So that is why if you have CH, if you have an adrenarchy, gonadarchy disconnect, you are more likely to have gynecomastia as compared to a primary androgen issue in that perspective. So it is expressed in adipocyte, growth plate, bone, brain, and various tissues. So what it tells us is that it is not just the effect in the gonad, its effect is in every different part. And that is why if males are treated with aromatase inhibitors, you might have some delay in epiphyseal fusion, but you will have effect on the testis, effect on the bone, and effect on prostate. Various other organs are affected. This again is POR dependent. So 3 enzymes we talked about, 17, 21, and you have got aromatase, which is POR driven, so to speak. So now aromatase will basically convert endostigm down to estrone and this to estradiol. And this estradiol can also be converted using 17 beta HSD. And POR is now controlling 17, 21, and aromatase. So this is pretty much the 5 major products. One was progesterone, which only requires side chain cleavage, star and 3 beta. Only 3 enzymes required. Cortisol, you require much more. You require side chain cleavage, star, 3 beta. You need 21 and 11B1. Aldosterone, you need even more. You need a 11 aldosterone synthase. For DHEA, you need this pathway, side chain cleavage star, and then 17 hydroxylase lyase to DHEase, which then converted into 3 beta HSD to andro, 17 beta to testo, and from there to estradiol. So these are the 5 different compounds which are produced in that perspective. Now, we have till now talked about production. We haven't talked about inactivation. And here comes in an important enzyme called as 11 beta HSD. So what is the function of 11 beta HSD 1 and 2, Naveen?
It is to protect the excess.
No, 11 beta HSD 1 and 2 separately, both of them.
The 11 beta HSD 1 is responsible for conversion of cortisol to cortisol. And 11 beta HSD 2 is responsible for conversion of cortisol to cortisol.
So 11 beta HSD 1 is the activator and 11 beta HSD 2 is the inactivator. So which tissues we would like to protect from cortisol effect?
So basically kidneys and on lungs.
So mineralocorticoid responsive tissues, because we know that cortisol has got equal affinity as aldosterone. Its level 1,000 times more. So if you allow this cortisol, it is going to really go ahead and cause hypertension, hypokalemic alkalosis. So there you will have more 11 beta HSD2, which will act like a shield against cortisol. Now, whether this 11 beta HSD2 will act at high level of cortisol or low level of cortisol? Only with high level of cortisol. So let's say if cortisol level is 300 nanomoles per liter, if it is 30, it will not act. What is the level of aldosterone? It's picomole. So even if you have 30 nanomole per liter of cortisol, it will become 33,000 as far as picomole is concerned. So you want to do it at 0 level. You don't want to have any escape. So this 11 beta HSD2 will have a very low Kmax. It will start acting even if one part of cortisol is there, it will kill it in that regards. But the 11 beta HSD1 is a different one. It is potentiating the activity. So when you have slightly high level, till a particular level, it will not work. But it will start working when you have a particular level, it will start working. But if it becomes too much, it will go the reverse way. So 11 beta HSD1 is a bidirectional enzyme, higher Kmax. Its main role is to potentiate the cortisol effect. But if you have too much, it will work like a safety valve. 11 beta HSD2 is mainly to protect. So it will kill any cortisol in a mineralocorticoid responsive tissue. It has got a very low Kmax in that perspective. And this is further regulated using NADPH. The NADPH is again an electron donor, we know. It depends upon the hexose pathway. So H6-PDH is important. So if you have a problem in H6-PDH, what will happen to 11 beta HSD1 effect? So what will happen is that this enzyme is normal, but your substrate is less. So this is known as apparent corticosterone deficiency. Synthesis deficiency is there. This is not because of the enzyme, but because of the substrate. So this is also now a known cause of cortisol deficiency. So now our pathway extends cortisol shuttling between cortisone using 11 beta HSD2 and 11 beta HSD1 in that perspective. And this is regulated via NADPH through the H6 hexo-6 phosphate pathway. Now we know that we have produced DHEA predominantly from the adrenal. Adrenal is not producing too much androstenedione. It is not producing much testosterone at all. So its major product is DHEA. But this DHEA, if you just use it like this, it will be like a cash, it will be spent. It will cause hyperandrogenism, but after some time there will be deficiency. So body needs to sulfate it, and this DHEA is converted into DHEAS sulfation. And this is done using SULT1A, which is the important enzyme, which is regulated via another pathway of PAPS and the PAPS SS2. Now, PAPS SS2 ensures the sulfation of DHEA. If you have a defect on sulfonyl transferase or PAP-SS, what will be the manifestation?
Whenever we want to produce, we don't have that time. So ultimately, we are in this.
So how much DHEA deficiency will do what? You are worried about DHEA deficiency or excess? So there will be excess. So you will have hyperandrogenism. So this will present with hyperandrogenism. DHEA deficiency, otherwise how many primary adrenal insufficiency do we give at DHEAs? It is, people say, quality of life, weakness, fatigability, but it is not a major thing to worry about. Excess will cause virilization. So this is a known differential of PCOS. PAPS excess is a known differential. So if you talk about now rarer forms, you can say aromatase deficiency, non-classical form, POR deficiency, PAPS defect. These are all differentials of quote unquote PCOS, and they are actually adrenal hyperandrogenism in that perspective. So now sulftransferase basically acting at the level of DHEA, converting it into DHEAS, and then you have got a particular enzyme PAPS, which is regulating the overall process. Now, the final aspect is this was a classical pathway we discussed, cholesterol going on to produce 17-OHP, which is producing andro, testo, and going towards DHT. But now we know that 17-OHP doesn't get converted into androstenedione to a great extent. So how do fetus get virilized? This was a big question people were thinking. Till the time a new pathway was discovered, which was known as the backdoor pathway. Now, backdoor pathway plays an important role in fetal adrenal, which basically is a shortcut. You don't need to remember everything. 5-alpha reductase and aldo-keto reductase, they will convert 17-OHP directly to DHT without involving testosterone. So you have a direct 17-OHP connection to DHT without andro, without testo. So this is the backdoor pathway, which is majorly responsible for virilization. 7-DHC is converted by DHC7 to cholesterol, which is then sulfated and has lipase using this LIPA and esterase, which is cholesterol sulfate. This cholesterol is converted, is pushed to the mitochondria by star and converted there by side chain cleavage into pregnenolone, which then is acted by 17-hydroxylase and lyase to produce DHEA, which is sulfated to DHEAS, which requires a PAPS pathway as well. Now, this is then converted by 3-beta-HSD in the liver, in the testosterone to produce, in the testis to produce testosterone, which is then aromatized using the mitochondria, using the aromatase in the ovaries or in the lipid tissue to produce estradiol. Now, lipid also, as discussed, has a role. If you have 3-beta-HSD there, you will have 71-hydroxylase to produce DOC, and this 11-hydroxylase will produce cortisol, and from there it will produce cortisone using the 11-beta-HSD. And finally, we have the aldosterone synthesis to produce aldosterone. The enzymes are side chain cleavage and star just in the beginning. Then you have 3-beta-HSD, which has got peripheral conversions, hydroxylases and lyase, and then you have got 21 and 11 hydroxylase, which are the major ones. As far as testosterone is concerned, we've got 17-beta-HSD and aromatase.